Okay, we can go on. Now there is the presentation by Peter Schultes. Peter Schultes is a colleague from Zurich, Switzerland. He's a former president of the AGT and chair of the Training Standard Committee. Was my teacher, in a way, in the Training Standard Committee about the training standard in the AGT some years ago. Peter is involved in different projects of research from a Gestalt therapy point of view, and I'm glad to give the words to Peter. So, please.
Thank you. I will try if that micro is also working. So, hello everybody. I'm glad to have the opportunity to present a research project that we have developed and done in Switzerland, including 10 different modalities. And two universities were involved, one from Germany, Cologne, and one from Zurich, the School for Applied Psychology in the University for Applied Science. It is a quantitative and empirical research, and I dare to present it, although Ken has formulated some critics to this, because I think I agree with the critics that RCT designs are crucial for psychotherapy and will produce artifacts because they are too far away from the reality of the practice of psychotherapy. But this doesn't mean that we cannot do some empirical research also. And I didn't like too much this opposition of research in Gestalt therapy can only be done in qualitative designs. So, oops. Okay. So, as an introduction, I would like to say something about the Swiss Charter for Psychotherapy. I was the president, or still am, the president of this association. It's an umbrella organization of about 28 different institutes in Switzerland which have a certain standards of education in psychotherapy. And in this association, we have a scientific declaration which obligates all the members to undertake some research activities, to show that they are taking care to get the feedback of what they are teaching, what they are practicing, if this really has an effect on clients, and to develop in this way their own modality. Something that Margarita also has pointed out, that this is an important effect of psychotherapy research. We don't oblige the members' associations to undertake research in a certain paradigm, but we demand from them that they can show some research in at least two different paradigms. So not only qualitative, but also quantitative. But in the quantitative designs, there are a lot of varieties, and we never obligate them to make randomized control studies, because we have the same critics to these, as Gianni has mentioned and as Ken has mentioned. So the development of our design took us about 3 years until our scientific committee, the delegates of all the member institutes and the two involved universities have come to a setting when where we all could say this kind of research is something that fits to the subject of psychotherapy. And the project was running then over 6 years. It ended at the end of 2012, and now we are in the phase of evaluating and publishing articles on various questions that can be described. Here you find a list of the involved psychotherapy approaches. You see it's quite a variety. Missing is the Rogerian approach. Missing is the cognitive behavioral approach, and missing is also systemic approach. They are not members of our umbrella organizations, but we invited them. But they hesitated to participate. One is for money reasons, because this was quite an expensive project, and they didn't want to pay for it. And some of them also were afraid that if they participate, these other modalities, from where some of them don't have much published in research results, that if they reach same results or similar results, this might be a damage for their own approach. So therefore, I agree with Ken saying that research is also related to politics. But we have at least psychodynamic approaches, we have body-oriented approaches and humanistic approaches, including Gestalt therapy. Here is an overview of how many therapists and how many patients have participated overall. So in green you see the Gestalt therapy. All in all, there were 81 therapists included and 362 patients, which is quite a large number for a research project. Here I can show you an overview of our design. So you see the red, these red lines. So this is outcome measurement that we did at the beginning of the therapy, at the end of the therapy, and the follow-up measurement 1 year after finishing the therapy. And at the beginning, of course, we also had some baseline documentations to do. In the blue things, you see that we have used OQ45. I will show later a list what this kind of instruments have been used. So OQ45 we used at the beginning, at the end, and at the follow-up, and after every 5th session. OQ is a scale of how big the suffering on certain symptoms is. We wanted to combine not only outcome research but also process research and see how this makes movements during the process of the therapy. And in the green things here, you see that we have also used every 5th session a questionnaire about therapeutic relationship, about the alliance, and after every session, all the therapists filled in a scale of interventions, how often they have used certain interventions. I will say something more about this, just to document what was done during the therapy, because we saw there is a lack in empirical research concerning the Dodo verdict. We don't know why the Dodo verdict exists, because in most of the research designs, nobody investigated what was really done, what kind of interventions were really done. They just said, these are Gestalt therapists, these are cognitive behavioral therapists, these are psychoanalysts, and that's it. But nobody has investigated what did they really do in form of their own interventions. And we wanted to know something more about that. So here I will describe you some of the outcome measurements that we used. This is a self-rating by the patients, the outcome questionnaire of Lambert and all, and others. And then we used the brief symptom inventory. Maybe not to lose too much time, I will go a little bit forward. A depression inventory, BDI 2, a sense of coherence, SOC9, K, INC, which is incongruence questionnaire, and FMP, this is about the motivation for psychotherapy. And then we had at these 3 points, at the beginning of the therapy, end of therapy, and 1 year later, an external rating by independent assessors, because we were interested to do a naturalistic design. This means we didn't want that the therapy process of the investigated therapy is too much influenced by the therapist. And usually we Gestalt therapists or also other psychodynamic therapists, bioenergetic therapists, they do not use a lot of such instruments of measurement, and to keep the influence of the design of the research very low, we decided to have external ratings by independent assessors which were trained in using these instruments. So there was the SCID interview 1 and 2, the Global Assessment of Functioning questionnaire, GARF, which is a global assessment of relational functioning, and OPD2, which I think some of you know. It's coming from psychoanalytic therapy. And we also had some documentations, basic documentation about the patient at the entrance and at the exit. And some basic documentation about the therapist also, some general informations about his professional education, his professional experience, his age, and things like that. Then, as I told you, we were not interested not only to have an outcome design, but also a process measurement. So there we used this patient's questionnaire after every 5th session, which was a self-rating by the patient. And then we had an external rating after each 5th therapy session by the therapist. So he had to document the dates of his sessions, and he had to fill in the therapist version of the HAQS, which is a measurement for the therapeutic alliance from the perspective of the therapist, and the corresponding questionnaire is as a self-rating by the patient from his perspective. And we used what I told, an intervention list after each sessions to document what kind of interventions were important in this session. Therefore, we have developed a manual, and we have described 100 different interventions for to be used by external raters who were listening to audio-taped recordings of the sessions to identify what kind of interventions they could find. And they didn't know in what method this therapy is going on, so they were blind in this case. And these 100 interventions, they consist in 20 general interventions, which happen in all modalities, and between 8 to 10 modality-specific interventions that were elaborated by the participating schools. Here is an example of this, how we did it in this manual. So we had a definition. Therapist confronts directively patient with recurring dysfunctional patterns in relationship or with presumably neurotic behavioral inconsistence. And then we had a more, how to go back? Yes. We had an operational description. Therapist addresses patients' behavioral inconsistencies, addresses recurrent problems in patients' relationship, points out instances of incongruence on different levels of expression. And then we had a discrimination to other interventions that might be similar. So this was a help for the training for the external raters to distinguish between the different interventions. And at the end, we also gave some examples. So you can see the therapist says, you seem to be you seem to repeatedly slip into such situations, or this is something you experience quite often, don't you? These were some examples. I would like to show you also an example of modality-specific interventions. I don't know if you can read it, if it's big enough, but you will get these slides. And so here we have developed for Gestalt therapy a list of typical interventions that Gestalt therapists use. So the question was, if somebody observes a therapy session, how would he identify that this is Gestalt therapy being used here? And so we could recur to a researcher, Bernd Fliegener from Germany, who already has started something like this. And then we have extended this in asking all of the main teachers in a Gestalt therapy training institute in Germany and Switzerland to ask, what kind of interventions would you say they are really typically for Gestalt therapy? We offered them a list of these interventions, and they gave us a rating. This is really typical. And out of 12 interventions, then we have chosen these 10 interventions. At the side, you see the therapist documented after every session on a scale between 0 and 10 if this intervention was not used at all, or if it was often used in this session, or if it was very important in this session, then he could give a higher score. And in point 30 at the bottom, there was the question, what was the percentage that I think I have used specific interventions of my modality? And the question at the end was, do I think these interventions, the modality-specific interventions, were suitable or unsuitable on a scale between 1 and 5? This was a self-rating by the therapists. The external raters, they have chosen then by random 3 of the sessions of the beginning phase, middle phase, and ending phase, and they rated these sessions also. This gave us a possibility later to compare how the self-ratings and how the ratings of the external assessors differ. I will show you something about this later. Now I want to present you some results over all the therapists and modalities, and to show the importance of the psychotherapist with regard to the treatment outcome. So you can hear already in this title, it's not the modality that has the highest importance for the treatment outcome, it's the psychotherapist, as other research also have shown already. So what we did with the results was all the pre and post scores of the 4 outcome measurements, I will show you a table of this later, were transformed into T-scores. This is a statistical method with a multiple outcome criteria. So we used the brief symptom inventory pre and post, the outcome questionnaire OQ45 pre and post, the Beck depression inventory pre and post, and the global assessment functioning scale pre and post, and compared this. The sum of the T-scores at post measurement was subtracted from the sum of T-scores at pre-measurements, so post minus pre. The change scores were then factor analyzed. A one-factor solution with an eigenvalue of 2.699 resulted, which is quite a clear factor. And he was the only factor. And each of the 237 therapies resulted in a factor score. Factor scores of all patients from the same therapist were averaged, resulting in 68 scores. because we were 68 therapists. These 68 factor scores were then clustered analyzed in a hierarchical cluster analysis. A three-cluster solution emerged. There were 13 very successful therapists as Group A. There were 33 moderately successful therapists in a Group B, and there were 22 least successful therapists in a Group C. I can show you a box plot of the therapists. These are the three clusters that appeared through this statistical analysis. This is something for statistical specialists. The main thing is 3 differently effective groups of therapists appeared. So 44 cases of 13 Group A therapists were very successful. 132 cases of 33 in Group B therapists were moderately successful, and 61 cases of the 22 Group C therapists was least successful. Here you see an overview overall the groups with A therapists, B therapists, C therapists. These are just the numbers. First, well, you want to see it longer? No. You will get it also in writings. So I prefer to say something about our conclusions. They are clearly differently affecting psychotherapists. More effective therapists have higher response rates. They have less dropout rates. But no therapist is successful throughout all his cases, and no therapist unsuccessful at all. Approximately 2/3 of Group A therapist patients have a chance to be clinically significantly changed. Approximately 1/3 of the Group C therapist patients have a chance to benefit clinically significantly from the treatment. Approximately 33% of Group A therapist patients may not benefit, and approximately 33% of Group C therapists may benefit significantly. This shows variations even in the results of the same therapists, regardless if they belong to A, B, or C. So these were the pre-treatment scores. It's too much just to go through all these results. You will see it on the slide. But I come to the conclusions again. Patients seen by Group A therapists had more severely psychological burden prior to treatment than B and C group patients. But not B therapist patients compared to C therapist patients. They had about the same load of psychological burden. This result may suggest that patients' severity of psychological problems was critical for the differences in therapists' effectiveness. So it's not just the therapist, but also the burden of suffering or the amount of suffering of the client which influences the outcome. So here we show you a result of an univariate analysis of variance. The 3 red factors, they have statistically significant influence. The others could be neglected. So the therapist effectiveness grouping, severity of psychological problems, and the combination of therapist effectiveness group and severity of psychological problems were the main factors. So our third conclusion, both variables, therapist effectiveness and patient severity of psychological problems at treatment entrance predict independently treatment outcome. Patient severity of psychological problems explains approximately 25.5 percent of the outcome variance. Therapist effectiveness explains approximately 18% of the outcome variance. The interaction between both the variables explains approximately 23% of the outcome variance. Thus, one can resume that although both variables are statistically independent from each other, that an interaction effect between both variables explains more of the outcome variance than therapist effectiveness alone. The quality of treatment alliance, as well as professional experience of the therapists, did not play a significant role with regard to treatment outcome, which might be surprising, especially the treatment alliance, the quality of the treatment alliance. So what kind of clinical implications does this have? So we have to face that there are differently effective psychotherapists. Therapists' effectiveness is not due to their theoretical orientation or to their school affiliation. Therapists' effectiveness cannot be sufficiently explained by the degree of their professional experience. Also, therapists' degree of treatment adherence. Treatment adherence means if somebody, let's say a Gestalt therapist, was sticked to more modality-specific interventions or was using more general interventions, this did not play an important role, as we have shown in another paper. Other factors such as therapist competence may account for the difference between psychotherapist effectiveness, and this will be one of our next steps in our projects, to have an eye on that. Patients with more severe psychological problems, with a higher psychological strain, they have a better prognosis to benefit from psychotherapy. Patients with more severe psychological problems have a better prognosis if treated by more effective psychotherapists, no matter what their diagnosis may be. Now I would like to show something about treatment adherence and outcome overall therapists and modalities. As I said before, the independent raters had to rate by random selection 3 sessions for the objective ratings over the length of the therapy. These are some statistical marks. Here you find a drawing that shows that IBP at the very right side, they have the highest rate of practicing modality-specific interventions. And on the left side, IBP is integrative body psychotherapy. And on the left side, you see so the blue score is specific interventions. And on the very left side, you see SGTA. This is transactional analysis. They have the lowest score in using modality-specific interventions. Gestalt therapy is somewhere in the middle. SVG stands for Gestalt therapy, Swiss Association for Gestalt Therapy. And in the red column, you see the non-specific interventions. You see how much more non-specific interventions have been used than modality-specific interventions. And the yellow column is interventions from other modalities, including a Rogerian approach and cognitive behavioral approach for rating the interventions. We also want, and systemic approach. We also wanted to have these because we know that also these approaches might influence the selection of interventions by therapists from other schools. So you can see that almost all therapists use more interventions, either general or from other modalities, than their own modality interventions. And this was quite a surprising result. And this might be an explanation for the Dodo verdict, that no one has researched until now, why the total verdict comes out. So here you see a scale of which interventions from other modalities have been most chosen. You see the green one for Gestalt therapy. So the most often interventions from other school came from psychoanalysis, from cognitive behavioral therapy, and from systemic approach. Here we tried to find out what kind of, how the treatment specificity has changed between the beginning of the therapy and the last session. So the blue measurement is for session 5, and the red measurement is for the last session. So you see that everyone has reduced during the therapy the modality-specific interventions. And on the left side, you see the results for the unspecific treatments, and in the middle, moderately unspecific treatments, and on the right side, the results for the relative specific treatments. So we come to some conclusions. Across modalities, we identified and operationalized a wide variety of intervention categories. The range from initiative towards behavioral interaction to recommending imaginative work, from direct assignment to free-floating attention. There is a spectrum of overlapping categories, non-specific or essential but not unique. Therapists predominantly work with these, with a score of 50 to 70% of the interventions. Essential and unique interventions from all modality were less than 20%. Techniques from other concepts are being used to an approximate extent of 10% up to 35%. Most of these latter intervention techniques from other concepts come from psychoanalysis and client-centered therapy. However, treatments are successful on an average. There is no correlation between treatment adherence and outcome could be found. Thus, it can be speculated that the outcome equivalence paradox in psychotherapy is due to the relatively high proportion of unspecific interventions which are seemingly shared by all psychotherapists. So far, we find a trend that intervention specificity seems to be higher with less experienced therapists and only moderate with more experienced therapists. Further data analysis may reveal if specific disorders, the severity of patients' distress, additional therapist variables, or certain phases of the therapy related to high versus low intervention specificity. Now I would like to present you some gestalts for the group of gestalt therapists participating in this project. There were 7 therapists participating, 5 female, 2 male. 23 therapists were fully documented so that we could evaluate them. All in all, there were more than 30. I don't recall the right number, but there were more than 30. But some of them had missing data, so we couldn't use them for the evaluation. The average age of the therapists was 49.3. Between 35 and 65, and the average age of experience was 11 years, which is quite high, and differing from other research projects where usually the therapists are beginners. But you see, it's also a quite high range here, between 2 years and 32 years of experience. Here, I can give you an overview of, let's stay with the scale diagnosis. 1 means a diagnosis in the group F3, 2 means F4, 3 means mixed depression and anxiety, and F6 is group 4. And then we had a severity cluster. You see this in the right scale. 1 is very good, 2 is relative, this 1 is low, 2 is middle, and 3 is high. And on the outcome cluster, you see very good outcome with under number 1, relative good outcome with number 2, and no change or negative outcome with number 3. So like this, we could show that the same therapists have different outcome with different clients. This is comparing the whole group, on the left side, the whole group of modalities, and on the right side, Gestalt therapy. The difference in the result of pre and post. There's more variety in Gestalt therapy's population. And here is, according to the OQ45, the difference with a difference effect of 0.17, which is not very big different. But on the GAF scale, there's a higher difference again. And this is the same with the BDI, depression intervention, depression symptom scale. So overall, we had the results for Gestalt therapy. P means the statistical effect, which shows that all these results are significant. So we had good changes overall diagnosis with the measurements of these 4 scales between pre and post, and which shows that Gestalt therapy is quite successful. But it showed that for F4, the group of F4 in ICD-10, and especially for depressive reactions, there were much more convincing statistical results. You see this on the P scale again. The lower the number, the more significant it is. And then we have compared with the other diagnoses, and you see that they are much less significant than depressions. So we come to conclusions. The effects overall diagnosis groups are quite good and comparable with the other investigated modalities and other reported results in international literature. The effects in group F3, affective disturbances, are highly significant, high, especially for patients suffering on depressions. Depressive patients seem to benefit highly from Gestalt therapy, better than from any other investigated modality, and better than reported in international literature. Depressed patients showed at the beginning of the therapy a higher severity of psychological problems, which makes these results even more important. The effect in other disturbances are much lower on middle effect size and lower than in other modalities and research projects. This was a result that that was rather disappointing. But it's important that these results cannot be generalized because the sample of therapists and patients was statistically not really big. So maybe if we would have had a bigger sample, maybe some other results would have appeared. So here I would like to show you some provisional coherences. In the blue scale part, you see higher severity of psychological problems at beginning of therapy, and then in the screen scale, less experienced therapists stay with amount of modality-specific interventions. This was a trend that we could show. And at the bottom, the more experienced therapists reduce the amount of modality-specific interventions. And here, this in relation to the outcome result, a difficult relation with a therapist that use lower specificity shows a better outcome result. And somebody in a good relation, but with a therapist with a higher specificity, comes also to better outcome results. Difficult relations combined with higher specificity and good relation combined with lower specificity shows lower outcome results. This gives, of course, some more questions to do some further investigations to explain this outcome. My last remarks, there is more research needed, especially for Gestalt therapy. We did not succeed in the Swiss Gestalt community to motivate enough Gestalt colleagues to participate in these projects. There are about 200 Gestalt therapists in Switzerland, clinically practicing, and only 7 were ready to participate in this project. And another conclusion is a naturalistic design for outcome process studies is more adequate than any RCT design. We investigated therapy in the very normal way it is doing in private practices. And we will publish in the near future in several journals results to different aspects, and there will be also some case studies with qualitative approach in longitudinal process over whole therapies based on tape-recorded sessions, which we can connect with the empirical data that we have found. So some of the therapists were ready to tape record every session. So we really have, we can analyze the whole therapy process. Thank you for your interest. And for further information, please consult our website. And if you want to contact me with any further questions, that's my email address. Thank you.
Thank you, Peter, very much for this presentation and for keeping the precise timing too. Thank you very much. And thank you everyone for keeping your attention. It's not so easy to sit and listen only, but thank you for that, and keep your attention because we have Phil Brownell's presentation now, and I welcome Phil here. I'm very glad you came to Rome from Bermudas, and that you are here and you're present to us. Welcome.
You hear that? We have 4 cats at our house. I grew up as a dog person. I don't know how I became the owner of 4 cats. But I sometimes think that doing research is like attending to the litter box. Nobody wants to do it, but it's got to be done. Let me take a moment and get this teed up, and then I'll continue.